Hi, my name is Salam and I'm here with Mark, Beck, Arya, and Rashmi. Today we'll be discussing the case of Mrs. Joseph and breaking down the clinical manifestations, pathophysiology, diagnostic tools, and the pharmaceutical actions. I'll begin by discussing the clinical manifestations that Mrs. Joseph presents with that caused the escalation of a MET call. Starting with breathing, the respiratory rate of 38 is in the red zone and the patient is tachypneic. It is also noted that on auscultation, a diffuse crackle is heard. This confirms that there is a buildup of fluid present in the lungs, and Mrs. Joseph is currently suffering from a pulmonary edema. Due to the buildup of fluid in the lungs, the patient presents with a decreased oxygen saturation of 86% on room air, and this is increased using supplementary oxygen. Moving on to circulation, the heart rate is at 113 beats per minute resting, which is tachycardic. Mrs. Joseph's heart rate is compensating for the low blood pressure of 88/62 by the activation of the sympathetic nervous system. The sympathetic nervous system increases the heart rate in an attempt to bring up the blood pressure, but it is not the case in this patient due to her hypovolemia, and the blood pressure still remains low. Hypovolemia in this case is caused by fluid leaving into the extra-arterial and capillary space, such as organs like the heart and other tissue, causing the pitting edema and a panasystolic murmur. For disability and exposure, Mrs. Joseph is noted to have a reduction in her CGS of 1 point and also needing assistance to mobilize. This is expected for an individual who is both hypotensive and has high blood glucose levels, resulting in cell starvation, improper function of organs and cells due to being poorly perfused and leading to a lack of oxygen reaching the cells, and glucose not being able to enter the cells. It is noted that the temperature is at 37.8, which at this stage leads us to believe that Mrs. Joseph either has an infection or her brain function is altered due to her symptoms. The low-grade fever that the patient presents with is further exacerbating her condition due to the vasodilation that the fever causes. The pitting edema is, as discussed earlier, is caused by improper heart function, which is further confirmed by her right JVP pulsation. Mrs. Joseph is also a diabetic and is experiencing a hypoglycemic event, which is concerning as glucose is needed by all cells and tissue to function and survive. The discussed above are all of high importance, therefore triggering a MET call. I will now be passing you over to Mark, who will explain this further.
Thanks, Salam. Hey, my name is Mark, and I will be describing the pathophysiological links that correlate to the disease conditions being experienced by Mrs. Joseph. Essentially, I'm going to elaborate on the 3 high-priority clinical manifestations that Salam has formally identified. The 3 clinical manifestations that have developed in Mrs. Joseph as a result of her deteriorating condition are severe respiratory distress, circulatory instability, and some neurological deficiencies have also developed. The patient is experiencing severe respiratory distress as both of her key indicators for breathing fall into the red zone. Mrs. Joseph is suffering from tachypnea as her resp rate was measured to be at 38 breaths per minute. Her rate of breathing has significantly increased as her body is attempting to increase its oxygen intake and expel excess carbon dioxide. Mrs. Joseph's body is doing this in response to her hypoxia, which is evidenced via her oxygen saturation levels only reading at 86% on room air. The onset of hypoxia in the patient is likely a manifestation of the pulmonary edema that has struck the patient. The excess fluid in Mrs. Joseph's lungs is restricting the heart's ability to efficiently pump blood throughout her veins, resulting in blood seeping into her lungs, and it is this interstitial fluid that reduces the normal movement of oxygen throughout the patient's lungs. In relation to Mrs. Joseph's poor circulation, she is tachycardic, whilst also hypertensive, which together are signs of cardiogenic shock, possibly due to her heart failure. The patient's heart is not pumping sufficient amounts of blood throughout the body, thereby resulting in the patient being hypotensive, which the body tries to mitigate by increasing the heart rate. The patient is also suffering from a pansystolic murmur, as seen on her electrocardiogram, which suggests that she could have one of 3 valvular heart diseases. The patient also has a bilateral pitting pedal edema, which is an indication of fluid overload that has occurred as a result of the heart's inability to sufficiently pump blood throughout the body, thus leading to the accumulation of fluids. In relation to the neurological changes experienced by Mrs. Joseph, her GCS is only 14, and so she is not fully oriented to time, person, and place. The patient's GCS is likely a manifestation of her hypoxia, which has decreased her cerebral perfusion. The patient's serum sodium levels are also low, measuring at 128 millimoles per liter, indicating hyponatremia, which can lead to the onset of cerebral edema and thus contributing to her deteriorating cognition. It can be deduced from Mrs. Joseph's symptoms that she is possibly suffering heart failure, which is likely the root cause of her severe respiratory distress, poor circulation, and neurological deficits manifesting. Over to you, Beck.
Hi, I'm Beck, and I will be discussing question 3. Chronic cardiac failure, if left untreated, can progress to acute pulmonary edema, which is what Mrs. Joseph is diagnosed with. Due to Mrs. Joseph's complete heart block back in 2022, this would indicate that the myocardium has suffered ischemia and caused cell death within the location of the ischemia. Once the heart has suffered from cardiomyocyte death, the heart is unable to contract as effectively due to the myocardium wall becoming thicker and rigid. This also affects the heart's stroke volume, contractility, and the workload of the heart increases. When the heart's cardiac output reduces, the blood flow also reduces, which leads to the activation of the renin-angiotensin-aldosterone system, also known as the RAAS, which causes vasoconstriction and increases blood volume. This then sets off the sympathetic nervous system to constrict blood flow even more and release the antidiuretic hormone, which causes further water retention within the body. In 2022, Mrs. Joseph was diagnosed with a left ventricle ejection fraction of just 29%. A normal heart's ejection fraction should be above 50%. Mrs. Joseph's heart is unable to effectively contract and eject the correct percentage of blood out of the ventricle, which leads to the pooling of blood within the left ventricle. When the ventricles are unable to eject the correct amount of blood, it will dilate and try to compensate for the amount of blood needed to be ejected, but this just leads to extra blood pooling within the ventricle. The heart tries to eject the extra blood, but due to the weakened contractility of the myocardium, the heart is unable to eject the extra blood that it has accumulated within the ventricle, so the blood just pushes back through the mitral valve and into the left atrium. Once blood is pooling within the atrium, it can flow back into the lungs within the pulmonary capillary bed and will sit within the lungs and affect gas exchange and increase pulmonary pressure. Mrs. Joseph is experiencing sudden onset of chest pain and a productive cough due to her heart's cardiac pressure being reduced, and the workload of her heart has increased, causing her blood to increase in volume, which is then leaking into her lungs, causing pulmonary edema. I will now pass over to Arya to explain question 4.
Hi, I'm Arya and I'll be discussing question 4. The 2 significant diagnostic results that are found in Mrs. Joseph are her creatinine level and her chest x-ray results, which are both closely related to the pathophysiology of congestive cardiac failure leading to acute pulmonary edema. As per the pathophysiology of Mrs. Joseph's creatinine level, consider her chronic renal impairment. In congestive cardiac failure, it reduces cardiac output, which leads to renal perfusion. It decreases the response of the kidney by perfusion and activates the renin-angiotensin-aldosterone system. It will increase sodium and water retention to improve cardiac output. Moreover, congestive heart failure will not handle the increased volume, which lead to an overload of fluid and increase the symptoms of heart failure. In Mrs. Joseph's case, her GFR is 15 ml per minute, which indicates severe renal impairment. It will reduce the kidney's ability, will release the waste product, control the fluid overload, and make it apparent through pulmonary edema. The creatinine level reflects that it has decreased renal function, which has worsened her volume status, leading to subsequent heart failure. This cycle of heart failure may worsen her renal function and decrease her clinical aspects. The chest X-ray reflects fluid overload and cardiomyopathy. The chest X-ray reflects fluid overload and cardiomyopathy, which can be found in patients with chronic heart failure. While the heart could not handle the overload of blood, it is back into the pulmonary circulation, which leads to increased hydrostatic pressure. In the pulmonary capillaries, the pressure forces the alveoli, and the gap between these tissues can cause pulmonary edema. Cardiomyopathy is a heart covering system where the ventricles improve to manage the increased blood volume. Looking at Mrs. Joseph's chest X-ray clearly shows signs of pulmonary clog and cardiomyopathy. Fluid overload diffuses the noises heard on the chest, auscultation, and the low oxygen saturation while having high flow oxygen. The cardiomyopathy related to her history mainly decreased her LVEF by 29%. It increases and shows how the heart reflects chronic overload and insufficient pumping, which contribute to the blood flow in the pulmonary circulation. The backflow of the blood can cause pulmonary edema, which can cause shortness of breath and both effective coughing and breathlessness at night. It reflects on the cold parts of the body, which may lead to heart failure due to diagnosis of heart failure. I will now pass over to Rashmi to explain question 5.
Thank you, Arya. My name is Rashmi Shakya and I'm going to discuss about question 5. As in the case study, Mrs. Joseph has diagnosed with acute pulmonary edema and congestive cardiac failure. The two drugs that could be used to improve her clinical condition are intravenous furosemide and intravenous nitroglycerin. Furosemide worked by blocking the tubular co-transport of sodium and chloride to the proximal, distal, and thick ascending loop of Henle, resulting in the excessive water excretion along with the excretion of sodium, chloride, and magnesium, as well as calcium. In the case of Mrs. Joseph, who is presented with severe respiratory distress and evidence of fluid overload, furosemide plays a critical role to reduce fluid overload in acute pulmonary edema. Furosemide promotes diuresis that reduce the amount of fluid in the intravascular and interstitial spaces, which improve pulmonary congestion and respiratory function. This drug also reduces preload and afterload, which reduce the risk of future heart failure. Intravenous furosemide can be given 20 to 40 mg, repeat at intervals of at least 2 hours until the desired diuretic effect is obtained. It works primarily by blocking the reabsorption of electrolyte from the kidney and enhancing the excretion of water from the body. The adverse effects of the furosemide are mostly related to the dose, such as electrolyte imbalance, dehydration, metabolic alkalosis, increased creatinine concentration, hypotension, etc. But in the situation of Mrs. Joseph, she might face electrolyte imbalance, which can cause cardiac arrhythmia. As Mrs. Joseph has a history of cardiomyopathy and the insertion of a pacemaker, it is essential to monitor her electrolyte on the regular basis. This includes blood tests for potassium, magnesium, and renal function. In addition, it is necessary to monitor for the sign of dehydration and hypotension because excessive diuresis can lead to the complication. The second drug that can be used for Mrs. Joseph is nitroglycerin because it is a fast-acting vasodilator and manage chest pain due to acute coronary syndrome. It is also used to treat pulmonary edema and aortic dissection. Nitroglycerin increases blood flow to the myocardium and decreases cardiac preload and afterload. This reduces stress on the myocardial wall and improves anginal symptoms. It is also reduces coronary artery spasm, decreasing systemic vascular resistance as well as systolic and diastolic pressure. Nitroglycerin helps reduce preload and afterload by reducing the heart's workload and improve its efficiency. In the case of Mrs. Joseph condition, who is suffering from acute pulmonary edema due to congestive heart failure, reducing preload significantly reduce the amount of congestion in the lungs, improve oxygenation, and reduce the work of breathing. Also, by reducing afterload, nitroglycerin decreases myocardial oxygen demand, which can improve cardiac output in the heart that is already suffering from a low left ventricular ejection fraction of 29%. The main side effect of the nitroglycerin is hypertension. It can be the major concern for Mrs. Joseph because her pressure is already very low at 88/62. While administering, it is necessary to monitor her blood pressure to control the risk. This dose may be carefully titrated so that desired effect is obtained without causing severe hypotension. If hypotension occurs, then the infusion rate should be reduced or discontinued, and other supportive measures have to be implemented, such as providing IV fluids. Thank you.